Okay, let's scratch really quick. So I just showed how I use design thinking and theory to create information displays for critical care. Now I will show you how I'm using the same process for putting theory into practice with health services research, where the health information technology was just one of several interventions. So again, research shouldn't be done alone, but the team has changed a bit. So this is a grant proposal that I'm looking to do for lung cancer screening in low-resource primary care clinics. So I now have a cancer researcher, an implementation scientist, a health services researcher, a health IT expert, and a general primary care practitioner. So this is surprising to me, but it may not be surprising to John. But in 2019, in the United States, lung cancer was responsible for the most cancer-related deaths, and was the second most frequently diagnosed cancer. And for the cancers that we routinely screen for, lung cancer caused approximately 58% more deaths in women than breast cancer, and about 142% more deaths in men than prostate cancer. So those were interesting numbers. So smoking is this leading cause for lung cancer. And unfortunately, these underserved populations have some of the highest rates of smoking. Also, these populations are less likely to be screened, and this together really causes this twofold increase in lung cancer deaths compared to higher socioeconomic populations. So the U.S. Preventive Services Task Force recommends a low-dose computed tomography or a low-dose CT scan for people who are currently smoking or quit less than 15 years ago, are aged 55 to 80, and have more than 30 pack-year history of smoking. And what I mean by 30 pack-year history of smoking is 1 pack a day for at least 30 years. So substantial smoking exposure. So now screening has risks of false positives that can lead to unnecessary treatment. So depending on patient risk factors, up to 95% of these positives can be false positives. So due to this risk-benefit trade-off, in order to get paid for a low-dose CT scan, you have to go through what's called shared decision-making. So it's this process of the provider communicating with the patient and really gathering the patient preferences and values to go through and pursue a treatment pathway. So due to shared decision-making and other barriers as well, less than 5% of patients that are eligible in the United States undergo this screening. And in these low-resource clinics that we're targeting in Utah, less than 0.1% are currently screened. So we had an idea. Let's get a killer application so these providers can perform this shared decision-making, and then they can bill for this service, and the screening will go up, and everything will be great. So we did this. We created an app. There was lots of data behind this risk prediction. The information was comprehensive. The visualization was in line with these other patient-facing displays. Usability and informed decision-making, this app performed very well. So basically, designers and testers loved it. But we thought that maybe we should test this in a live environment before saying this is a good solution. So while in practice, as it turns out, everybody hates this app. There's too much information. The provider said it wouldn't fit into their workflow. It takes too long to use. The patients hated it because there was too much information to consume while the provider was looking over their shoulder. So I'm not going to go into the process of how we streamline this application, but this is what it looks like now. So it's basically a single screen that has a risk prediction that stratifies this patient into one of these bins for discussion, and then it has quick and brief bullets to work through with the patient more quickly. So the bottom line is this. These primary care providers have about 1 to 2 minutes to discuss lung cancer screening. So So from this simple finding, from prototyping, had reframed this entire health IT implementation for lung cancer to a lung cancer screening program implementation. So basically the question now is, how can we remove all of these barriers to make that 1 to 2 minute conversation meaningful? So our original funding opportunity was leveraging health information technology, so health IT, to address minority health and health disparities, which was really primarily targeted at this health information technology, and in our case it was that shared decision-making application. Now we are focused on a separate funding opportunity. So this is dissemination and implementation science for cancer prevention and control in low-resource environments. So this is mainly focused on this implementation strategy and this package of interventions. So we need to get some more information. So we started visiting clinics, trying to figure out what's going on. So after visiting the clinics, we found that there are lots of barriers. So as it turns out, they are gathering smoking status, but not smoking history. Most providers don't actually know the screening criteria well enough to identify patients. And patients face stigma and clinician bias with that connection between smoking and lung cancer. And most of the time, these imaging centers where these patients would have to go in rural Utah are further away than their primary care clinic. And providers don't have these tools, and I mentioned this before, but they don't have these tools to make this shared decision-making process easy and the documentation easy. And also, patients have other priorities they want to discuss, so lung cancer screening may be just down on the list. And then finally, these resource clinics may not have the extra resources for the personnel that may be needed to put in this lung cancer screening program. So to simplify this, I would say that a lot of these could be helped by removing some of these structural barriers. But I would say that there are some wicked problems in this list as well, with the stigma and provider bias and patient priorities being some of those. So one of the key differences between lung cancer and other cancers is this close link with smoking. So many people with lung cancer are blamed, or they blame themselves for this disease. So a good example of this stigma is from this Bloomberg News article that reads, "America's heaviest smokers don't want to know that they have lung cancer." But this stigma has been shown to prevent providers from offering lung cancer screenings to some of these most at-risk patients. But however, when we talked to these patients, we found, which was also consistent with the literature, that they were unaware of lung cancer screening, receptive to screening, and also open to being contacted about screening, and even some patients would consider quitting if they had a positive screening test. So getting back to our process. So with the idea of closing this gap between this provider bias and patient preferences, social influence theory seems to fit nicely and has lots of experimental studies that we can build from. So social influence is one of the most potent behavior change theories. It refers to the way that we change our behavior to match the social environment. So there are two key components that include internalization and compliance. So internalization is really adopting a decision by aligning your values to someone else's. And then compliance is this act of responding favorably to a request offered by others. So to illustrate these theories and apply them to this context, if we can get patients to internalize the idea that lung cancer screening may benefit them outside the clinic, then possibly the patients will come in and get their providers to comply with opening this discussion on lung cancer screening. So this answers the idea of what might work. The next question is, how are we going to reach this very targeted group of low-income, rural, heavy smoking patients? So this technology is not new, but it seems to be increasingly the best way to reach this population. Nearly all rural patients have cell phones, and approximately 70% of them have a smartphone with some sort of mobile broadband capability. I don't know if that's the same here. That is the case in the United States. So there's some data behind text messaging for breast cancer and colon cancer screening. We also have a lot of data on how providers comply with patient requests. I mean, Think about this direct-to-consumer advertising. It's a big thing in the States as well. What we don't have is how texting can influence lung cancer screening discussions. We also don't have a lot of data on how this smartphone capability and this functionality can help get patients more informed around screening. So my next prototyping and testing project is to gather pilot data and set up a study for when this project is funded. So I'm planning to prototype this prompt timing, such as before the appointment and after smoking status changes, the content such as exploratory or information gathering, how personalized or generic this message needs to be, and also how this interactivity can further information, and with further information this can help get these patients informed. So for example, this first message is more general, exploratory, to get smoking history, and then really to assess their responsiveness. The second message is much more personalized, contextual, with information that's gathered from the electronic health record. So the data on these contextual messaging is really mixed. I think some people think it's a little bit unnerving to see what sort of data others have on you, but others think that this sort of messaging is worthwhile because it shows the patient someone or something is going through their data. And then finally, short and sweet might be the best way, with more information upon request. So for example, if we can get them to enter some of their information into the tool before visiting the provider. So the idea is that we want to get this good balance of information so this patient will internalize this message and then bring it to the provider's attention. So overall, we want these patients to be educated about lung cancer screening and then empower them to discuss this with the provider. And then for providers, we want them to screen more by embedding these tools into their workflow for the patients that smoke. And we also want to give them these tools to facilitate the shared decision making as well. And then finally, we want to remove all these structural barriers, including training, transportation, screening data, to really cultivate the benefit from this 1 to 2 minute encounter. So this is my final slide. I know it's boring, but so overall, I hope you learned that healthcare problems can be wicked. Think back to that malpractice case where they were overriding all alerts. What about my father-in-law's case where the diagnosis was maybe buried under a mountain of data? And then lung cancer screening where this shared decision-making tool, which we thought would fix everything, just becomes one part of a larger solution. And then the clinician behavior is key to outcomes. So in each of my examples, I showed that behavior complicated the problem and was also a big factor. And then theories can guide this prototyping and testing solutions to change this behavior. And again, with each of those problems I showed, we applied different theories. And then finally, the next time you or others want to set up another pop-up alert to change behavior, please consider exploring other solutions as well. Thank you.